Welcome to today's MESTD Learning Community webinar. Today we'll be hearing from Amy West on the intersection of homelessness and infectious disease. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all questions until that time, or you can place them in the chat feature in Zoom. Slides and materials from today's webinar will be sent out in the follow-up email. And now I'd like to give a quick introduction to our speaker today. Amy West is a family nurse practitioner who currently practices in addiction medicine at Penobscot Community Healthcare. Prior to working at PCHC, she worked for Boston Healthcare for the homeless program, both as an RN and an FNP for 9 years. While working in Boston, she developed a passion for helping patients navigate barriers to quality healthcare. She has been able to continue this passion with PCHC and their community partners. And with that, I'll hand it off to Amy for our presentation. Thank you all for being here today.
Thanks, Bethany. Hi, everybody. Like Bethany said, my name is Amy West. I'm a nurse practitioner, and the majority of my background has been in homeless medicine as well as addiction medicine. And quickly becoming more familiar with infectious disease due to an HIV outbreak that we are experiencing in Bangor. And I saw Dr. Milton on here, and I see Dr. Gass. So quick shout out to the folks at Eastern Maine Infectious Disease for helping me learn all of the things as quickly as I possibly can. And feel free to correct me if you guys notice something that you're like, that doesn't seem quite right, Amy. So let me share my screen with you all. All righty, and we will play. All right, and I apologize in advance because this slide may advance without me allowing it to. So hopefully by the end of today's webinar, you all will have an understanding of the epidemiology of homelessness in Maine, understand what social determinants of health are and how those impact care delivery, as well as the way that our patients who are unhoused access care, as well as infectious diseases that are most likely to impact our patients who are unhoused and how best to manage them. As Bethany said, I have no disclosures, and this thing is really wanting to give me a hard time. So I always like to set the stage around stigmatizing language and using non-stigmatizing language. Our being mindful of language is incredibly important with our unhoused population. Therapeutic relationship building and trust are vital to being able to work with folks on reaching their healthcare goals. So the way that we speak does impact that. Many of our patients have experienced trauma at the hands of healthcare professionals. So the way we speak does create an environment where they're wanting to see us again or not wanting to see us again. And if they don't come see us again, then we can't do much to help them, right? So we really want to be mindful of language that we're using and try to use person first language. This is a ever evolving a slide, for lack of a better word. These are all words that I used myself in medicine, and over time have had to adjust my own language. So we all catch each other, and no one is perfect, and I don't expect anybody here to be either. It's just something to be mindful of. Homelessness in Maine. So homelessness across the country and in Maine is measured through a point-in-time count. So one night a year, typically January, one of the coldest nights of the year, we volunteers gather and actually measure our folks that are living outside. So we measure folks that are staying in shelter, transitional housing, and folks that are rough sleeping or sleeping outside. We kind of break off into regions, and we go out one by one and we count individuals. So when you're looking at this data, it's slightly skewed. It looks as though numbers are trending down as of 2024 data, but unfortunately that is due to the loss of COVID-19 emergency shelter funding. So you can see here that persons in shelter these numbers continue to rise, and yellow is where that person's in emergency motels is dropping. So unfortunately, even though the data does look like homelessness is improving in Maine, it actually isn't. It's actually growing. Mainehousing.org has all of these slides, and you can kind of toggle through all the different breakdowns of the data that we see across the state. So it can be broken down by gender, by race, by age, as well as looking at this slide in particular. The thing that I really am saddened by, but not surprised by, is this chronically homeless number rising. So folks that are living unsheltered chronically or long-term. This slide I also find incredibly interesting because Maine breaks down our point in time numbers by hub. So you can kind of find your county based on your hub and then look at the numbers for that particular hub. So I am hub 7, I'm in Penobscot County. And one of the things that really pops out at me is that proportionately speaking, we have a lot more unsheltered folks that are living outside than some of the other counties when we're looking at percentages. So that's important to me as a provider that's delivering care to individuals that are living outside, because that might mean I need to do more street medicine to find folks versus if I have, like hub 2, a lot of folks are sheltered there. I might target the shelter system as a way to catch my folks that are unhoused, to monitor them, deliver care, screen, or treat. That's the little epidemiology nerd in me comes out. Many of you all know this, but I think it's worth reviewing what social determinants of health are. So social determinants of health are non-medical factors that affect health outcomes. So things like housing, having a phone, job opportunity, education opportunity, all of these things greatly impact our health. But we forget that sometimes in the day-to-day of medicine, but it is very valuable for us to kind of frame this in our heads when we're talking about delivering care to folks that are unhoused. Understanding homelessness and understanding this really does shift the way that we deliver care. Patients really do attend to their hierarchy of needs. I'm sure many of you are familiar with this little pyramid. This is Maslow's hierarchy of needs. And when we think about our folks that are living outside, when your biggest concern is kind of where my next meal is coming from, if you're diabetic, you might not care that it's pasta, or you might not care that it is something that's going to spike your sugar because you're just grateful to be eating. We'll also see this as folks go from living outside on the street to living in shelter. Sometimes their A1Cs really rise because they went from not having any access to food to access to food, but food that they don't have any control over, right? So it is really helpful for us when we're seeing those patients to understand that, because us as a provider, often what we are going to say when someone's A1C is going up is make sure you're following a healthy diet, eating diets that are high in vegetables and low carb and high protein. But when folks are living in shelter, they don't have a choice in that. And the cheapest food is the high carb food. So that's often what they're getting. We also will see this a lot with exchange sex or sex work, particularly when we're thinking about an infectious disease component, if folks are utilizing sex as a way to have their physiologic needs met. So exchanging sex for housing, exchanging sex for food, money. They might not have an option to have protected sex if they are going to be exchanging sex for a safe place to stay. So as much as we're going to say, make sure you're engaging in protected sex, obviously we're still going to give that advice, but we do need to be mindful that this is that person's reality and they may not always have a choice in that if they want a safe space to be that night. Trauma-informed care is key with this population. Many of our folks that are living outside have experienced immense trauma, whether that's childhood trauma that kind of drove them. Folks that have high ACE scores are more likely to be unhoused. So they may have experienced a lot of childhood trauma. Once you are unhoused, you're more likely to experience trauma, whether that's emotional or physical trauma through assault, as well as the trauma that unfortunately many of our folks that live outside experience at the hands of the healthcare system. So being mindful, just being aware that many of our folks have trauma can can color the way that we communicate with them and really increase the chance that we're going to develop a therapeutic relationship. People experiencing homelessness have more chronic health conditions, more co-occurring health conditions, mental health, substance use. They have a much greater all-time mortality risk. And the thing that's really heartbreaking for me is the average life expectancy of someone that's living outside is 48 years old. That's wildly young, particularly when we think about in a traditional population, a traditional primary care population. 40 and 45 is the age that we're initiating a lot of our preventative care measure screenings, right? Like colon cancer, breast cancer. That's when we're starting our colonoscopies and our mammograms. Our patients that are living outside are passing away before we're even initiating screens. And what I mean by that isn't that we shouldn't be encouraging those preventative measure screenings, but from a differential perspective, we also have to be considering what are our patients that are living outside more likely to die from. It might not be breast cancer. They're not living long enough to get breast cancer. It might be an overdose, right? So that might be where we're really dedicating our time and energy for those folks is preventing harm. So we can ideally help them live long enough where we need to be worrying about their colon cancer screenings and their breast cancer screenings. We really want to keep our folks alive. Our patients that are unhoused are more likely to experience traumatic brain injuries. Obviously, like I said, mental health and SUD, PTSD, and cognitive impairment. So this is another thing that really kind of is heartbreaking for us is up to 80% of our folks that are living outside show signs of cognitive impairment. Sometimes that is due to mental health, but a lot of times it's from anoxic brain injuries or from an overdose or an assault. And when we think about, again, the difference when we have folks that are housed and a more traditional primary care panel, folks that have a significant cognitive impairment or a TBI often have family members that are helping them navigate the healthcare system, right? Our folks that live outside often don't have family to help them navigate the system. So that keeps our patients that are living outside from accessing care because they literally just can't even navigate. They have a hard time making a phone call, understanding instructions, if they're lucky enough to even have a phone that's active. So again, when we're thinking about how do we manage medicine for our folks that are living outside, these are the things to keep in mind. And oftentimes, even as a new provider myself, I would say, oh, well, it's not important enough to them, right? If they were really worried about their diabetes, they would come into their appointment. But maybe it's not a situation where it's not important to them. It's a situation where they really are unable to navigate the healthcare system the way that we've set up the healthcare system to be navigated. So when we're talking about managing medicine in an unhoused population, again, priority number one is always to gain trust and develop a relationship with a patient. If they don't trust you, they're not going to come and see you. And if they're not coming to see you, there's nothing you can do to help them. The mindset of what can I do to help this person should trump what can I do to treat this disease. And they are slightly different, right? Sometimes the priority that day is getting somebody fed, not necessarily making sure they have, a high fiber, low carb diet. They're starving. We just need to feed them. And then we'll figure out how to manage their diabetes better for them as we continue to work with them over time. It is beneficial to treat symptomatic complaints first when we're dealing with our folks that are living outside, because that's their priority, right? So when we're talking about trauma-informed care, it's patient-centered, meaning what are the patient's goals, not what are my goals. So the patient's symptom might be, I have this hangnail, Amy, and my concern is, you have a murmur. There's a new murmur that I'm hearing today, but that's not necessarily physically bothering them, so that's not the priority for them. They're not worried about getting an echocardiogram done. They want me to manage the abscess on their foot. So developing short-term realistic goals with our patients so that we're coming up with collaboratively with measurable goals to help folks feel like they're actually accomplishing something can go a long way when we're talking about creating a therapeutic relationship. Many of our folks that are living outside are coming into treatment with advanced disease, right? For all the reasons we just talked about that keeps folks out of care. Often by the time they do connect with us, it's because they are very sick and they feel very sick, which typically means their disease stage has advanced. And now we're kind of dealing with a much more significant treatment plan than what we would have been dealing with if we were able to engage with them a year, 2 years, or even just 6 months earlier. Collaborating and communicating closely with your community partners is also vital when we're talking about creating a safety net to manage care for our folks that are living outside. Like I had done in the beginning, I'm shouting out Eastern Maine, the Northern Light Infectious Disease team in Bangor, because I wouldn't be able to do the work I'm doing with our HIV positive patients without their help. So creating those relationships with the team in your area, whether that's your specialists in the area, whether that is your housing navigators and shelter, or your shelter staff, community outreach workers, your peer outreach workers, having that safety net is really what helps patients receive not just care, but like really good quality care to manage those more advanced diseases. Having a harm reduction mindset, again, is really valuable. So for instance, our folks with an opioid use disorder, I would love everyone to be coming into treatment, being placed on medications for their opioid use disorder, if that's something they want to do, connect them to group and counseling and all the things. They might not be in a space that they can do that. That's really hard to do when you're living outside. So maybe my goal is, let's keep you alive. Here's some Narcan. There's an HIV outbreak going on in Bangor. Here's how you could get access to clean needles. So infectious disease. When we're talking about infectious diseases with our folks that are living outside, it's really important for us to consider, again, where are they sleeping? A lot of times it's a congregate living environment. So a lot of times it's transitional housing. A lot of times it's shelter. If folks are newly housed, a lot of time it's single room occupancy units where they're sharing bathrooms and they're sharing kitchens. So when we're talking about differentials, with a patient that does present to you, it's important to keep that in the back of your mind. Right, we will see more tuberculosis in this environment, and not just what we see more. So not only are we managing the patient that's in front of us, but we have to think from a public health perspective, who's around that patient, what's the setting that they're in, and how do we make sure the community of our unhoused patients is safe, not just the person that's in front of us. So this is where vaccines, really encouraging vaccines for our folks that are living outside, is so vital. COVID, flu can rip through a shelter so quickly. And again, knowing that our folks that are living outside or newly or are living in shelter often aren't engaging with their healthcare team or have much advanced diseases, like we think about like COPD, right? They're more at risk for having complications from COVID and flu. This is all stuff we know, obviously, but again, just like layering on that second bit of when folks are unhoused, what do we have to think about? Differentials, again, like I said, shift when you're dealing with a population that's living in shelter or living outside. When I was living and working in Boston, we had a rash of patients that had this pneumonia that just like was not responding to a traditional treatment course. We could not figure it out. People were getting hospitalized, and then we really started to track back. That was all coming out of one shelter, and it was a Legionella pneumonia that was through the showers. So all the steam in the showers was just increasing that transmission of that pneumonia. So not something that you would typically see in a housed population, right? You wouldn't expect that to be happening necessarily and affecting as many people as it affected in Boston. Norovirus and C. diff, again, norovirus like rips through the shelters. When we think about our folks that are living in tents, can you imagine having norovirus living outside with no access to a bathroom? I don't even like to think about norovirus when I'm living inside, let alone living outside in a tent. So how we navigate and manage and support patients that have norovirus that are living in a tent, making sure they have access to fluids, right? Many of our patients don't have access to clean drinking water or enough clean drinking water. So how do we figure out, are they safe? What to do if they're getting really dehydrated? Where can we connect them for fluids if needed? And C. diff, we just had a situation recently where a patient was discharged from the hospital after being inpatient for IV antibiotics for a couple of weeks, and came out, was complaining of diarrhea in the warming center. And we saw it and we were, oh boy, that if you've seen or smelt C. diff, it's hard to miss. So not only did we have to figure out how to manage this patient, obviously the warming center was not a space that he could manage a C. diff infection, but also that's a bathroom that about 20 other people used before and after him, right? So we have to think about, from a public health perspective, again, how do we provide that anticipatory guidance to the population, to the location, and to the patient? IV use. So a lot of our folks struggle with substance use disorder that are living outside. IV use is a big driving factor for a lot of the work that I do in street medicine. Abscesses are significant. And we always have that kind of question in our head, like to IND or not IND, right? Like in a housed population, I have a nice, like juicy fluctuant abscess. I might want to cut that open and give that patient some relief. But if folks are living outside, they don't have access to drinking water. How are they going to keep those wounds clean if I open that up? Do they have access to wound care and dressing supplies if I open this up? Is it better to maybe give them some oral antibiotics and a hot pack and hope we can get that to resolve without opening? Xylazine is a veterinary sedative that is cut into fentanyl. It's cut into fentanyl to make it more potent. The tricky thing that we're probably a lot of you folks, particularly the folks that work in infectious disease, are aware of is these terrible venous stasis type ulcers that are folks that are using fentanyl cut with xylazine experience. It does not matter if you're smoking it, snorting it, or injecting it. You can develop these ulcers. It doesn't matter if you're injecting it in your arm, you can get the ulcer on your leg. So there's no correlation to the site of injection. They are really slow to heal. They can be incredibly painful. And these are a couple of pictures of xylazine wounds. So the way that we manage those, I try to manage them like somewhat aggressively if there's a cellulitis around it, which most of the time, honestly, there is. These are the preferred antibiotic regimens that I use. Again, shout out to Dr. Gass. She helped me tweak my regimens and I got much better results after I tweaked them with her advice. So I like the Augmentin, the amoxicillin clav for twice a day, 7 to 14 days. And if they have an amoxicillin allergy or penicillin allergy, I will use the Bactrim. And the biggest thing that I found made a big difference for my patients responding on the street was instead of one tab as the double strength, I have been using 2 tabs as the double strength with Flagyl. And it's made a really big difference with rapidly improving the response than when I was using 1 tab or, shame on me, clindamycin. I've gotten much better results with this regimen. Wound management is really important. Like I said, our patients don't have access to wound supplies. They often don't have access to clean water. So educating our patients on, if the wound's wet, make it dry. If the wound is dry, make it wet, and providing them some wound supplies to keep with them, as well as how do they access help if they need help. Many of our clinics, you need an appointment, and the way you make an appointment is with a phone. And if you don't have a phone, or you don't know what date it's, or you don't know what time it is, because you do have a phone, but your phone is dead, it's really hard to make it to those appointments. So at our Hope House clinic, we have walk-in hours. Patients can walk in and be seen. Again, IV use related infections, we're seeing a lot more epidural abscesses, a lot more endocarditis and osteomyelitis, osteo especially because we have these wounds that are just so chronic in nature and again, not being managed, and it just proceeds to these really terrible osteomyelitis. And this is, I think the ERs have done a phenomenal job at keeping these on their differential, but it's also, again, when we think back to the way that our patients experience care, you can imagine that someone that's unhoused with a substance use disorder presents to the ER or the doctor's office complaining of back pain. Oftentimes they're accused of drug seeking, right? There is kind of sometimes this perception that has gotten a lot better, but there's a perception that folks are just coming in to get pain medications, and patients really feel that and internalize that and get really honestly angry. And that really prevents them from wanting to seek care again in the future. So even if that was 5 years ago, that sits with people and they're genuinely afraid to go to the emergency room or the doctor's office and say they're having pain because they don't want to be accused of drug seeking again. So that's where having that trust and working with your community ERs is really valuable. So for instance, St. Joe's has care managers. I can call them ahead of time to say, hey, so-and-so's coming in. I'm worried they might have an abscess. Can you sit with them? Can you help advocate for them? So patients know they have a friendly face that they can actually have with them or has talked to the ER ahead of time for them to just be like, hey, there's a real concern going on. Certainly developing relationships with the folks that work in the ER is equally as valuable. A lot of times patients, once they get diagnosed and they get admitted up to the floor, now they're on the floor for 6 weeks, right? 6 weeks of antibiotics, IV. And you can imagine that for folks with a substance use disorder and probably undermanaged mental illness, which is often the reason they're using substances to manage this underlying mental illness, the hospital can be a very uncomfortable place to be for 6 weeks. Your pain tolerance or your opioid tolerance is different from years of fentanyl use, meaning oftentimes pain is really difficult to manage for folks. They may be in withdrawal. Those hallucinations have come back that they've been managing to kind of keep at bay with really heavy use. And it's hard to complete 6 weeks of antibiotics. So again, that's where the relationship building with your community partners can be so valuable, because you can reach out to the hospital to help advocate for your patients. Does the hospital have an infection or an addiction medicine provider that can meet with that patient to make sure that their substance use disorder is being taken care of? Are there care managers on the floor that you can reach out to check in on them? So that's, again, like the little bit of a difference when you're dealing with an unhoused population versus a more traditional population. Sexually transmitted infections. I would say we drastically underscreen for STIs when in our unhoused population. It's hard to test for STIs when folks are living in a tent because our folks have a hard time coming in for treatment. We're trying to deliver a lot of times as much care as we can to where the patient is. So from a street medicine perspective, I'm going to the tent, I'm going to the warming centers, I'm going to the library to deliver care. So what resources do I have to be able to screen folks in the moment? Because the other thing that we have to think of is if I have a patient that comes into treatment and does, say, a vaginal self swab for chlamydia or gonorrhea, how do I connect with them to deliver them the results? We have to think of those things too and kind of plan ahead. There are rapid tests available for syphilis and HIV. If you are going to do a vaginal swab for a patient with a vagina, making sure that have they had a sexual assault history? Perhaps they prefer to do a self swab versus a GYN exam because of an assault history. Are they comfortable with a vaginal swab? So thinking all these things through with your patients, again, that's that trauma-informed care approach. These are some really, really great resources for folks that are living, for any of us actually with STIs or treating STIs. DoxyPEP, so doxycycline post-exposure prophylaxis. The CDC has put out a really, I think, helpful tool on this, which is essentially prescribing a 200 milligram doxycycline dose for unprotected sex. So I think about unprotected sex. I also think about assault because many of our folks living outside have been assaulted or are assaulted. And DoxyPEP is one of the things that we can provide them to help prevent STI transmission. And then expedited partner therapy. So again, it is really hard to connect with our folks that are living outside to do screening. So if we do diagnose one partner, we can treat the other partner with expedited partner therapy. And this is a link to the recommendations. Essentially, you can send in a prescription to a pharmacy without having tested that individual. And I've done this. You don't need their name. You can prescribe it under expedited partner therapy. Ideally, we get the name. But in worst case scenario, you can send it under expedited partner therapy. HIV. So like I mentioned, Bangor is in the midst of an HIV outbreak in our unhoused population. Many of us know what HIV is, but it is a virus that attacks the immune system and if left untreated can lead to AIDS. There's about 38 million people worldwide living with HIV as of 2022. And there's a lot of pressure to get those numbers obviously to come down, but across the country, we're still struggling with having the rates of diagnosis decrease. Again, many of our folks that live outside struggle with substance use disorder, and those that have a substance use disorder are at higher risk of acquiring HIV. And about 10% of the new HIV diagnoses annually are related to injection drug use. So sharing needles and high-risk behaviors related to substance use obviously increases that risk for HIV. So we think about high-risk sexual behaviors. It's not just exchange sex. I just was having a conversation actually today with a patient where he was describing, I don't know why I do this, but when I'm using, I don't care. he described it as like, I don't even feel like me. All's my brain can tell me to do is get that substance in my body. So somebody that very logically knows I shouldn't share this needle or I should engage in protected sex, they don't feel that's not always the priority in the moment. And there's also great shame after the fact with those folks. So when we're providing that guidance, being really mindful of the way that we're delivering that guidance to them, because many of our folks already feel shame around engaging in risky behaviors. These are the current numbers for the outbreak that we're currently experiencing in Bangor, Maine. And if you've heard about this on the news, the way that this sometimes data is being presented is as if the only new HIV cases in Bangor, Maine are related to IV use, but the way that folks are considered part of the outbreak is if they have had IV use within the past year or are unhoused within the past year. So there are more HIV positive cases in our area that are not related to this outbreak, but this outbreak is very significant for this area. Typically in Penobscot County, we see 1 to 2 new HIV cases a year, with maybe one of those being related to IV use. So we've had 23 new cases in the past 18 months. The majority of our patients are co-infected with hepatitis C, which does complicate the infectious disease picture. And we are doing our very darndest at connecting folks to care. When we're talking about connecting folks to care, again, it's important to think about the way our individuals that are living outside access care, it is very easy to connect to infectious disease if you are a new HIV positive patient. Patients can self-refer, providers can refer. The team in Bangor is so easy to reach. The team in Portland is easy to reach. It isn't a situation of that the care isn't available. It's a situation of the way patients feel they're able to access the care. So whether it's not a priority for them because they're worried about where they're going to sleep tonight or eat, whether it's because they're in the midst of a severe opioid use disorder, whether it's because they're nervous or afraid or feel ashamed, there's a lot of reasons that folks don't engage with that care. So what can we do to bring the care to them? The CDC recommends HIV testing on everyone at least once in their life, as well as more frequently for folks that have risk factors. And I like to point out these risk factors because when we think about HIV risk factors, many of us are like, well, I don't use drugs, right? But people who have had sex with anyone whose sexual history they don't know, there's a lot of people, particularly in the adolescent and late adolescent category that I know would fall into this category. And we as providers can do a lot of education around what's considered a risk factor and how often should you be getting tested. So for the federal CDC recommends once per year, but the Maine CDC is actually recommending right now testing every 3 months for ongoing risk factors for HIV. How do we test and screen for HIV? There's multiple ways to test. These are the 3 most common that I've been utilizing recently: point of care testing, a routine lab, and nucleic acid testing. So point of care testing is such a great resource to have. Typically, we're using them fingerstick or oral, which is an oral swab. The oral test kits I hand out to patients. They can do it at home. It's this wonderful little kit. It walks them through it. It's even got like a little timer and like a pencil so patients can keep track of the time how long their test is processing. The turnaround time is quick, 20 to 30 minutes. It can be done at home. It can be done in the library. It can be done at a tent. It can be done really anywhere, but it is less sensitive and often does require confirmation. So we have had situations where patients have had a point of care done, the point of care is positive, and then we cannot get them to come in to do their confirmation testing. You can use double rapids, so you can use 2 different types of rapid point of care tests to confirm a positive HIV, which is helpful. So if you have an oral and a finger stick or 2 different brands of the finger stick, you can do a confirmation test that way if you're working with a population and you don't have either access to a lab or the patient doesn't have venous access. That's the other thing for us to consider when we're trying to decide how we're gonna screen folks. Is a lot of our folks with substance use disorder have really poor venous access, or they feel like they have very poor venous access because they've been stuck a million times when they're dehydrated and there's a lot of scarring. And again, there's a lot of shame around that anyway. So folks will even say to you, like, you're never going to get labs from me. I'm an impossible stick. No one can ever get labs from me. But if you have that relationship, oftentimes you can be like, can I try? And most of the time we are able to get enough labs from them that we can at least do an HIV confirmation test. So the venous draw, which is the routine lab, is a 4th generation antigen antibody, and that often will get reflex to confirmation. So check to make sure yours reflexes automatically, so you don't have to find people to do a second venous draw. It does take much longer to get the results, meaning we have to think about how we're going to find folks. And again, that's where community collaboration is so helpful, because you can utilize your outreach workers, your shelter staff, with a signed release. Make sure you're getting releases from folks when you're doing this testing. So I will say to a patient, hey, if I need to find you, are you okay if I reach out to the options team to help me locate you to find results? If they're comfortable with that, make sure you get the release, because you need to have those releases signed to be able to do a lot of this work. I keep them with me. Nucleic acid testing. The benefit to this is that you're obviously going to detect an earlier or an acute infection, because you're checking the HIV RNA. So I have had, particularly in the midst of this outbreak, folks that are negative on their point of care and positive on their nucleic acid testing, because it's just too early for their point of care test to be positive. So again, that's where if I can get a patient to come into the clinic and they're willing to do a finger stick in the moment, and they're willing to let me draw their labs, I'm gonna do both. So I can ideally give them a little bit of a peace of mind in the moment, and ideally that other testing comes back negative. But if it's not, we call a really early infection, and we can talk to the patient about how to treat them. Prevention is key, like any chronic disease. We want to prevent as much as possible, so we don't have to deal with treating. Knowing where your syringe exchange programs are, or how patients access those exchanges, is really important information to be able to share with folks. In Bangor, we have limited access, I would say, to the syringe exchange, only because of the way that our city is laid out. Like our syringe exchanges are located downtown, but folks aren't always downtown, and it's really hard to take the bus around here, and it's costly, particularly if you're living outside. Many of our folks don't have bus tickets or bus fare. So navigating that with folks, how do we work around that? How do we get you to clean needles? I had a patient once tell me, don't worry, I know I'm using cleans because I buy them on the street. And I was like, where are you buying them? Can we figure out how to get you to the needle exchange so we know for sure that those are clean needles and not used and just packaged and sold? The biggest thing I hope everyone walks away from that I've really changed in my practice a lot is utilizing PrEP. So pre-exposure prophylaxis is really effective at preventing HIV transmission, particularly around sexual contact, and not bad, I would say, about 74% effective at reducing HIV transmission in IVs. So oral PrEP is a daily medication that folks that are negative for HIV can take to reduce their risk of HIV infection. We have to make sure folks are negative for HIV before we initiate pre-exposure prophylaxis. There's 2 oral meds that we often reach for, Truvada and Descovy. And the way that those work is they block HIV replication in the body. The advantages to this are patients can have these meds on hand, and it's discreet, right? If they're able to keep their meds in a safe space or keep them safely on them, it's something that they just take once a day that no one necessarily needs to know what it is, and very effective when it's adhered to. Disadvantages, for the same reason there is an advantage, the disadvantage is folks have to be able to keep their meds on them. So when you're living outside, meds are lost, stolen, destroyed by the rain. If they're living in a tent and their tent is moved along, sometimes they're not able to gather all their belongings with them, and their belongings get destroyed. So those are things we have to think about as well when we're talking about oral PrEP in an unhoused population. And they're expensive. So if a patient's meds are lost, stolen, or destroyed, we have to work with the insurance company to do an early fill. And it's not impossible, but eventually, if many of our folks have main care, eventually main care says, We're not doing any more early fills. So how can we be creative? Can we work with the pharmacy to do shorter prescriptions? So if meds are lost or stolen, they can at least go pick up a new prescription in a couple of weeks instead of a couple of months. Who should consider oral PrEP? Anyone that's at risk for HIV or anyone that asks. So anyone that says, hey, can I be on PrEP? Yes, as long as you're HIV negative, yes, you can be on PrEP. Again, having those relationships with our community partners is so valuable when we're talking about education and prevention of HIV, because our non-prescribing partners have a different relationship with our unhoused folks than even I do as a prescriber. We have to think of, there's a power dynamic always at play when you are a prescriber and someone's engaging in care, even when we don't always think about it, but it is always there. So there is going to be a different relationship with me as a prescriber than there is as a peer. So engaging your peer workers in educating and connecting with folks and encouraging them to be on PrEP if that's something that is appropriate for them. Ideally, we get all these beautiful labs before we initiate pre-exposure prophylaxis, but in reality, a negative point of care is all you need. Again, ideally, we get all of those labs. That is ideal. In a high-risk population, particularly for our folks that are living in Bangor and using IV, I'm going to often initiate PrEP on a negative point of care if I can't get the venous labs. And this is a great resource as well for more information on PrEP guidelines. There's a long-acting injectable PrEP that's also really valuable for our folks that are living outside. It is a once a month injection for the first 2 months. So you get like loading doses, month 1 and month 2, and then you go to every other month injections. Lenacapavir just came, MaineCare approved it for off-label use just recently. And that's a once every 6-month injection. I'm still a little anxious to use it. I'm still waiting for some protocol development from the experts in the field, but I cannot wait to feel comfortable reaching for lenacapavir when I understand how to use it safely more, because that will be a big game changer for us. It's really hard to find folks every month or every other month for their injection. And the biggest disadvantage to the injections is this long tail. So what that essentially means is if patients are past due for their injection, so if they're due on the 1st of the month and they go to the 2nd week or 3rd week of the month, you lose that protective factor. So there's still medicine in your system. There's not enough medicine to necessarily prevent HIV acquisition, but it's still present for up to 12 months, meaning if you were to contract HIV, the HIV virus has now been exposed to not enough of the medication to prevent it, but the medicine is there, which means it increases your risk for developing resistance to ART, so antiretroviral therapy, because you've had just this low level medication in your system as you develop and acquire HIV. It doesn't necessarily mean we shouldn't use it. It just means we really need to educate our patients around that risk and come up with a plan B. For me, that is, hey, if I cannot find you for your next injection, it's really important that you take the oral PrEP. So it's really important. I'm going to send a prescription to this pharmacy. If you can't find me or I can't find you, please go to the pharmacy and pick up those oral medications. And they're going to need to be on them for about 12 months if there's still HIV risk ongoing. Ideally, they're on it for 12 months. There's follow-up labs with PrEP. Again, this is ideal in a perfect world. Often when you're working with an unhoused population, it is not a perfect world. But every 3 months, we'd be gathering some follow-up blood work, and then every 12 months, reassessing for a need. Folks that are unhoused, when it comes to HIV, are more likely to acquire HIV. They have often higher viral loads. We have an increased difficulty attaining and sustaining viral suppression. Viral suppression is like the gold standard. That's what we want to get for everyone, because if you're virally suppressed, your body is functioning optimally. It's unlikely that the HIV is going to be, or it's really impossible for the HIV to be impacting you in a negative way if there is no detectable viral load. And that also means you can't transmit the infection. So U equals U is undetectable, means equals untransmissible. So from a public health perspective, there's also no risk. There is also increased morbidity related to HIV for folks that are living outside. And when we're looking at folks living with HIV that are housed versus unhoused, if you're living with HIV and you are unhoused, you are less likely to receive housing than those without HIV. you are more likely to inject drugs than people living with HIV that are housed, and more likely to engage in exchange sex than folks that are living with HIV that are housed. So again, we have to think about this from both a public health perspective and how we kind of navigate these barriers for our patients. ARTs are very effective, but they can interact with medications like methadone. So again, not that you shouldn't do it, but work with your partners in infectious disease to either figure out how to manage this or make sure your partners in infectious disease are aware that your patient is taking methadone. We really need to both manage the mental health and the substance use disorders in conjunction with the HIV with a really integrated treatment plan. Again, just speaks to the importance of having appropriate releases and working closely with your partners in infectious disease to make sure everyone's on the same page. Medication storage is a big one. We talked about it briefly. So how do we help patients navigate having their medicine, keeping it safe, remembering to take it? The way that we've been doing this with the Bangor outbreak is we've worked with a pharmacy where we can package 7 days at a time. And every time that I go on outreach, I pick up the meds, or the outreach workers pick up the meds and we deliver them to the patient. So that way we know, one, they've got their meds, two, their meds haven't been lost or stolen, or we're working with folks to do the long-acting injectables. Anytime you can have a one-stop shop with wraparound services. So for instance, at your syringe program, can you also have low barrier SUD treatment, substance use disorder treatment? Can you have case management there? Can you have infectious disease treatment there, screening, STI testing, all the things? The more we can do in one place, the easier it is for our folks. We utilize street medicine in our community as well, and outreach workers. Housing is key when we're looking at HIV and in our on-house population. The more folks we can get housed, the more likely they are to reach viral suppression, the less likely they are to transmit it to others. So really pushing housing for our folks living with HIV that are unhoused. There is a long-acting injectable ART called Cabenuva. We're utilizing this a lot now with our unhoused population. Typically, you want viral suppression before you initiate this medication. So typically they'd be on an oral medication until they're virally suppressed, and then we can transition folks to Cabenuva. The nice thing is, again, they don't have to have meds on them. I don't have to find them every week to deliver their meds. They don't have to remember to go to the pharmacy to pick up their meds. But it does require us doing an injection, which not everybody loves. And I have to find you to give you the injection. And one of the things that we're utilizing for this population in particular is this thing called the Ward 86 protocol. And this protocol was created due to the complexities of managing HIV for folks that are living unhoused. And this protocol talks about utilizing the long-acting injectables, initiating those prior to viral suppression. Really fascinating stuff. So I put a link to that protocol in here as well if you guys are nerds like me and want to check that out. Hep C. So Hep C, most of our folks that have the HIV outbreak are co-infected with Hep C. There is acute Hep C and chronic Hep C. Both acute and chronic can lead to significant liver dysfunction, liver cancer, cirrhosis, and death. Maine, unfortunately, has the highest rates of Hep C in the country. And Hep C progresses faster in folks that are living with HIV, and Hep C co-infection also leads to higher rates of liver damage and liver failure. So that really just highlights for us, again, our unhoused folks are higher risk for acquiring HIV. They're higher risk for acquiring Hep C. They get them at the same time. Now we really have some issues with us. So our folks with Hep C really be pushing PrEP. Are we screening folks well for Hep C? Are we engaging folks in treatment for Hep C? So these are, the Maine CDC website has a lot of really interesting graphics, and you can really peruse all the acute and chronic Hep C information. But this breaks us down by county, the counties that are hardest hit. And you can see here that Maine is still significantly above the US rates, but is trending down, which is lovely. Similarly, with chronic Hep C, you can see the counties that are hardest hit, and again, still higher than the national average, but is trending down. And that has a lot to do with improved access and ease of treatment than there used to be. When I was just like a wee nurse, we used to admit patients in Boston to our medical respite for 6 months for them to do their Hep C treatment. And it was miserable, and patients were so sick, and very few of them completed the full course of treatment. It's way better than it ever was, and we'll talk about that briefly. So the way that we test for Hep C, there is point of care, so a finger stick for an antibody. And now there is a dry spot antigen. So there's an antigen finger stick, which is lovely because once you test positive for Hep C and your antibodies are present, they're always going to be present. So a positive antibody doesn't necessarily mean there's active viral load, there's active virus. Patients may have been treated or cleared the infection on their own. So if they have a positive antibody, it is important to test their viral load if you can to determine if they need treatment. And folks should be tested every 6 months, particularly for folks that use IV, but also folks that use straws, like don't think there's any risk for contracting Hep C, but sharing straws, like there is a risk for Hep C. So it's important to educate your patients on that as well. You can get clean straws most of the time from the safe syringe programs. And again, just like education for our patients around that. These are the two treatments I most often prescribe. I get no money for this. I already said I have no disclosures. I just want to put that out there. But these are the two treatments that I most often prescribe is Mavyret and Epclusa, oral medications, very well tolerated. We're looking at an 8 to 12 week course with really, really, really phenomenal treatment outcomes. And patients are like blown away. They can be in active use while you treat them. That is also different than the way things used to be. So just because folks are in active use doesn't mean we shouldn't treat them. We're trying to prevent morbidity and mortality. They should absolutely be treated and educated that just because we've treated it and cleared this infection doesn't mean that you cannot reactivate Hep C or get a new Hep C infection. It's like important for folks to be aware of that. There is a PA process for getting these meds covered by most insurances. It's not a hard process, but there is a process there. And again, thinking about for folks that are living outside, how are they storing their meds? How are they picking up their meds? Can we get in touch with them to repeat their labs? Hep B, I'm just going to talk really briefly about Hep B, only because we are seeing co-infection of Hep B with HIV as well as small spikes in the Penobscot County, at least around acute Hep B infections. So similarly to Hep A or Hep C rather, you can have an acute infection that may manage itself, or you may develop chronic infection. You may need to treat that long-term. So again, Hep B rates are higher in Maine than they are for the US. They are trending down. For Penobscot County is really slammed again. And similarly with chronic Hep B, although Southern Maine's a little harder hit than Penobscot County. The reason, again, we care about Hep B is when we're talking about guiding our patients around risks for hepatitis, and a positive hepatitis B infection does impact the ARTs that infectious disease can pick, or can impact the treatment plans that infectious disease is utilizing if they're positive for hepatitis B. These are some really interesting resources that I've learned over the past year. This just got released. It's so interesting. It's a HIV and Hep C clinical guidance that the Maine CDC put together. It's so jazzy. They have like these algorithms and it's like just a really provider friendly resource to navigate like, how do I test? Who should be tested? What do I do next? What do I do if I have a positive test? What do I do if I have a negative test? Who do I reach out to? It's a really helpful clinical resource. And then this app I actually just downloaded recently. Also, if you're a nerd like me, there's just so much information in here. It's easy to access, it's easy to understand, and it's great if you work in the field like I do. It's kind of at your fingertips. All right, so that's me. I will stop sharing in case anyone has questions.
There were a couple questions in the chat, but before we go to them, I just want to share that the survey is in the chat, and I link a lot of things in the chat today. If you have any specific training questions or training requests, you can request that from the learning community with our technical assistance line. Also, I feel like this is connected, but we are doing a Train the Trainer on applying harm reduction principles in person in Augusta on April 22nd. It's free. It's 5.5 hours of CME and CEU. So if you would like to join us for that, the registration link is there. And we are having our annual conference in May. Unfortunately, we are I think we are completely booked for in-person, but if you would like to join us virtually, you can register at that link. But now I can go on to the questions. Bill asked, on homelessness on the chart for the homelessness by county, he noticed that Franklin County has a low rate of homelessness, and he used to work there, and that seemed low to him. And he thinks that it is very underreported, and there is a big shortage of services.
Yeah, absolutely. I thank you for bringing that up because I didn't mention that. oftentimes there's a lot of hidden homelessness that that's almost impossible to measure. Especially I find like in some of the more rural counties, it's certainly harder to measure, but we don't consider couch surfing. When I say we, I consider it homeless, but our folks when we're talking about a point in time count do not consider couch surfing as being unhoused. And it's really hard to measure couch surfing, even though we know folks that are couch surfing do not have stable or safe housing. So in my opinion, that should be considered unhoused, but when we're talking about numbers, it's not. And again, folks that are living outside have had really traumatic experiences interacting, often with police or healthcare organizations. So there is a lot of hidden homelessness that is impossible to measure. Well, understanding your community really helps you kind of navigate that.
Thank you. Doug shared a resource that Penobscot County Cares and the links there and for free transportation to testing and medical appointments. So that's really exciting. And I think there was another question Doug shared. If possible, would you address the reason or theories about why Penobscot County has been so adversely impacted?
Yeah. And this is obviously my personal opinion and my theory. I mean, Penobscot County historically hasn't had a great infrastructure for navigating healthcare for folks that are living outside. We just don't have a great infrastructure, and we have multiple organizations. I mean, every organization across the state right now is financially strained, right? So when we're looking at how do we stand up services as homelessness has risen, we need to stand up more services, but how do you support that financially? Because like ultimately we still all have to keep the lights on. So Penobscot County also, prior to this HIV outbreak, I don't think we did a great job collaborating. So like recognizing what each organization was good at and could deliver and provide for services, and how do we work together as a community for us to, as a team, deliver care to our folks that are living outside. So I think there's a lot of things at play, as well as an opioid epidemic, right? So all of these things have kind of interacted and created this like major issue that we're struggling with. And I feel like because of this outbreak, we are starting to try at least to figure it out. It's definitely brought a spotlight to the lack of infrastructure that our folks have that are living outside, and the difficulty that everyone has navigating the healthcare system, particularly our folks that are living outside, and at least motivated a lot of organizations to kind of navigate that and figure it out.
Thank you so much. I think, we have a couple more questions we can try to get to. Yeah, Doug shares that they're struggling with collaboration issue and that he'll be in touch.
Great.
And yeah, he agrees with the money issue. And Diane says, very well done. So much great information. And so, yeah, if there's any other questions, I think we have time for one more. If you think of a question later, please forward it to me and I can pass it on to Amy. And all of the slides from today will be in the follow-up email along with all the other links. But thank you so much, Amy, for this wonderful presentation. And thank you so much for everyone being here today. And we hope to see you again soon.
Awesome. Thanks, everybody. Thanks for having me.
Bye.